shoulder impingement, biceps tendonitis, rotator cuff injury. Many patients have been diagnosed with one or more of these conditions. What exactly is it? Well, we always want to start with an accurate diagnosis. Many patients that we see in the office have had x-rays, seen an orthopedic surgeon, oftentimes have had MRI. This model basically shows us the shoulder joint. It encompasses pretty complex anatomy. The rotator cuff muscles are seen here, 4 in total, 1 on top, 2 on the back side, and 1 in the front. The names aren't really important. What is important is the job of the rotator cuff is really to create congruency of the ball and socket joint. If we look at the actual shoulder, the ball and socket needs to be able to roll and slide for normal movement. It's an extremely mobile joint. Range of motion on the model is a little bit limited. Basically, the job of the rotator cuff is to hold that joint in its normal orientation, not allow the bone to shift forward or backward, and allow full range of motion. So it really centers the ball into the socket. If we were to look inside at the joint, we would see here that the socket portion is actually very small, similar to a golf tee. A lot of times the shoulder joint is actually used as an analogy to be similar to a golf ball on a tee. What happens is the job of the rotator cuff muscle in the front, known as the subscapularis, really is the biggest stabilizer of the shoulder joint in the front. Oftentimes we see that this muscle gets injured from repetitive motion or even traumatic dislocations, shoulder separations, or just years or decades of using the shoulder. We see this commonly in overhand athletes, baseball players, lacrosse, volleyball, and swimming. When this muscle becomes glued down, it becomes tight and weak, doesn't work right. It allows, again, the long bone, the humerus, to shift forward. If you look here, you can see this string representation. It's akin to the biceps tendon on this model. The biceps runs down from the upper arm and up and actually attaches into the shoulder in what's called the glenoid labrum. It's essentially a cartilaginous rim around the shoulder socket, gives it more surface area. Labral tears typically will occur up in this top portion of the shoulder, often called slap lesions. It's an anatomical descriptor for superior labrum, meaning on top of the shoulder, from anterior to posterior. Very common in overhand athletes, very common in weightlifters, CrossFit, etc. Many patients will actually have partial tears. They may not need surgery. There's 6 different classifications of labral tear in the shoulder. Some require surgical intervention, others we can treat conservatively. So how do we deal with this? Again, it all starts with an accurate diagnosis. Simply calling something a biceps tendonitis is not specific enough. We need to actively locate areas of restricted tissue, damaged tissue, that are restricting range of motion. One of the things that we'll see oftentimes is the tissues will get glued down here in the front of the shoulder, and the deltoid muscle that sits on top here will actually get glued down. So when we move the arm during a bench press or a push-up, or just moving the arm around, we'll create a friction here. This tendon will get inflamed, tendonitis. It's not specific enough just to coin the term biceps tendonitis. We need to figure out what's actually causing that. And the answer is, for most people, it's a combination of scar tissue buildup in and around the rotator cuff muscles and all of the other muscles that attach to the shoulder. We use a treatment called active release techniques, which is a hands-on manual therapy designed to locate and then release this scar tissue. Freeing up the range of motion in the rotator cuff muscle allows the muscle to work better, keeping the shoulder joint in a better position. And then we utilize manipulative techniques to the neck, upper back, and oftentimes the shoulder blade itself. And we combine that with corrective exercises, primarily in the shoulder, to focus on stabilizing that movement. We also work on range of motion of the upper back. And the combination of those things allows us to resolve the impingement and allow the shoulder to work and function better, allowing patients to get back to full activity, most of the time without surgery. In extreme cases, we'll do a collaborative treatment where the patient will have a rotator cuff repair. And then post-operatively, we'll still get in and do some active release techniques to the soft tissues around the joint that aren't typically addressed during an arthroscopic repair of the shoulder. Surgically, they go in and bypass these muscles and get into the joint to repair the damaged labrum or reattach a torn tendon. But the scar tissue issues that are inside the muscle tissue still need to be addressed. And that's where active release comes in. Shoulder impingement, complex condition, accurate treatment starts with an accurate diagnosis.
Great. We got a Don't move it if you can. You can point to things.
Okay.
Okay, go.
The shoulder joint starts in the front with the subscapularis rotator cuff. This is the front of the shoulder, the side, and the back. Looking here at the front, you can see the rotator cuff muscle sits on top of the entire front of the shoulder blade. Moving around to the side, the biceps tendon. On top is the supraspinatus, which runs along the top of the shoulder blade. And in the back, the infraspinatus, as well as the teres minor. The actual rotator cuff causes the shoulder joint to have continuity as it moves through a full range of motion. The rotator cuff essentially compresses the joint. The biceps tendon runs in the front here and attaches deep into the shoulder. The rotator cuff is often injured in an impingement syndrome, and biceps tendon running up is oftentimes inflamed, causing tendonitis. Shut's not cheap.
All right, hold it. Just hold it because I'm recording.